6 guest surgeons sitting in clinical consultation with you on such intraoperative problems as selection of abdominal incisions and suture material, hemorrhagic diathesis during surgery, aspiration pneumonia, monitoring the poor risk patient, and treatment of acute peritonitis. This is Audio Digest Surgery, Volume 17, Number 8. Our guest consultants include Richard L. Varco and Claude R. Hitchcock of the University of Minnesota Medical School, George H.A. Clues of Harvard Medical School, Louis R.M. Del Gurcio of Albert Einstein College of Medicine, J. Engelbert Dunphy of the University of California San Francisco School of Medicine, and Henry Gans of Cornell University Medical College. Program moderator is Dr. Varco, and it's his voice we hear now.
I'd like to call on the first speaker, Dr. Dunphy, on the problem of wounds and their suturing. Dr. Dunphy.
My view of where to make an abdominal incision is primarily based on where do you want to go and what the problem is. And I think all other considerations very often take second place to that. The build of the patient may determine what you want to do, and very often does. There's no question that the midline incision, for many purposes, is the ideal approach. It goes through an area which is essentially bloodless. It can be made rapidly, and for such conditions as abdominal trauma, penetrating wounds, to me it's the incision of choice, the only one which enables you to explore readily anything within the abdominal cavity. This incision, I think, has many advantages in the obese patient. It has the obvious difficulty that you may, if you're not careful, divide or injure or traumatize some of the intercostal nerves. Now, the right muscle-splitting incision, only advantage that it has over the midline is that it may be a little more lateral and you may get a little better access to a field. I will comment about the practice of making an incision and then retracting the muscle. And I think this is biologically unsound. I think the way to make an incision is to go right through what's in front of you. And that when you start raising elaborate flaps of fascia, you actually are taking the fascia away from the sources where it gets its nourishment, where fibroblasts come from, and where operative wounds get their basic tensile strength. And Dr. Jack Ferris some years ago made some observations on this, showing that any incision which mobilizes fascia, and particularly if it overlaps fascia, is a weaker incision than one which has a simply direct approximation of fascia, one edge of fascia to the other. And when you make another incision parallel to a previous one, you run a great risk of devitalizing the tissue in between. Even if the skin doesn't slough, you've got a problem of less blood supply to that wound than if you went directly through the incision. Now, if one goes directly through an old incision in the presence of a lot of previous surgery and a lot of adhesions, we know the technical difficulties that one encounters in that approach. Now, a few biological points. Here are some facts. This is taken from some very old studies of ours on the healing of the wound which has been reopened and sutured a second time. The ability of a wound which has been reopened and resutured to gain tensile strength faster than a normal wound is clearly established by any number of experimental observations, and this phenomenon probably lasts for somewhere around 3 weeks. So that when you have occasion to reoperate on a patient in that period, you can be certain that if the wound is not infected, that it will heal faster than a fresh primary incision. And it puts a great advantage, literally, in just reopening the same wound. Now, to me, one of the great situations to use this is where there's a question of a complication. Has he got a leaking anastomosis? Is there something not quite right? I've always felt that the place for the second look, rather than going back in 6 months to look for carcinoma, was to take a second look on any patient who has had a major operative procedure and now appears critically ill. There used to be a time when we thought the die was cast. We hope he'd make it. Maybe he'll die of heart failure. And today, it doesn't happen very often. But when it does, a second look to straighten outline anastomosis, relieve a kink loop of bowel, leaking duodenal stump, whatever it may be. If the complication appears to be technically approachable through the same incision, you've got every reason to do it, to reopen it. If you think you've got a major septic complication, on the other hand, the whole advantage rests with making a small lateral incision looking to drain an abscess, not going through the original main operative approach. I would point out, however, that this progressive gain in tensile strength that goes on over a long period of time is related to use. It's very obvious in the relation to a tendon repair, but equally applicable, I'm sure, to fascia and skin. And most wounds do not regain their original tensile strength, if ever, until 3 or 4 months. But in order to gain their strength, there must be stress and strain on the incision. This gain is a direct result of use of the wound. In closing abdominal wounds, we believe that the loose areolar tissue that lies on top of the fascia is the source of the fibroblast. I won't go into the evidence for this in the laboratory. It's very definite, and it's been tested in a great variety of ways. So when the surgeon comes down to fascia, and we all know those who do it, and carefully dissects fat off the fascia for a distance of 1 inch or more on either side, so he can place his sutures carefully or easily, he actually is doing something that is not biologically sound. I think you should go right through the fat and through the edge of fascia. Don't dissect the fat away from the fascia. One other point that I think is of considerable interest is that once the incision is made, that what happens after that has comparatively little effect on the rate of healing, unless it's a very prolonged healing period. For example, starvation before an operation has a deleterious effect upon the rate of repair. Starvation, which begins the day after the operation or when the operation is done, unless the entire healing period is in a burn, is dragged out for many weeks, has no effect. Starvation for the first 10 days after an operation has no evil consequences on a wound, provided the patient was well nourished at the time of the operation. The same applies to cortisone. If you give cortisone, patient is on cortisone, particularly high-dose cortisone, prolonged period of time, that definitely will depress repair. But if you put a patient on cortisone 2, 3, 4 days after the incision is made, it has no effect upon repair. A word about closure and sutures. We have no ideal suture. It just doesn't exist. What we would like, of course, is a non-reactive, quote, absorbable suture, and it doesn't exist. If the suture absorbs, it's reactive. If it absorbs rapidly, it's very reactive. If it absorbs very slowly, it's less reactive. For that reason, for most procedures, chromic catgut in general surgery has major advantages over a non-chromic catgut or plain catgut. In various procedures like in the eye, where they want the most minute amount of control and the disappearance of the suture very quickly, then of course an absorbable, very fine absorbable suture is desirable. I believe that the peritoneum should be closed. I'm sure that one can leave the peritoneum open and close the rest of the abdomen, and in no time, if you reoperated, you'd find that that surface was completely peritonealized. But I think the peritoneum should be closed with a continuous running suture, simply to produce a temporary water seal, simply to keep a bit of momentum or a little loop of knuckle of bowel getting into the operative field. Not because it provides any tensile strength, and not because it necessarily results in a smoother wound. There is some experimental evidence that if you leave the peritoneum open, and if a loop doesn't become adherent to the wound, the actual peritoneal surface, when it regrows, looks smoother than if you closed it by suture. But I think for mechanical reasons, a continuous running suture is the appropriate one with which to close the peritoneum, and it should be absorbable because it's a continuous suture. I don't think we should use non-absorbable sutures of great length, because if you do, you get a little infection around it, you've got a foreign body that you will never get out. There's no doubt that retention sutures contribute enormously to the tensile strength of the wound for the first 10 days. And you can use them in various forms. In the patient, the elective patient closing, let's say the straightforward colon resection, I like to use the so-called Tommy Jones far and near vertical mattress suture from fascia through peritoneum. And I use this visceral retractor so that it makes it easy to place. I call this the anti-anesthesia retractor because it prevents the momentum and so forth from getting pushed up into the wound during your closure. And I run this stitch, and about every 3 or 4 points stop and put in a vertical mattress. Then complete the fascial closure with a few non-absorbable sutures. When one has to get out in a hurry, and this applies to many patients with trauma, very critical situations, I think the appropriate closure is the through and through all layers retention suture, going from skin through peritoneum and out. Now, this provides superb tensile strength, and it's easy and quick to close. Why not use it routinely? No matter how carefully you do it, if you do it on every patient, there's the risk of suture crossing the abdomen. It has to be a non-absorbable suture, may erode a loop of small bowel. You can catch a loop of small bowel, but I'm sure that in addition to that, in a patient who's distended, that non-absorbable suture can be a pressure point, which in the presence particularly of a little peritoneal inflammation will lead to fistula formation. The other disadvantage is you've got it coming through the skin, and in a certain percentage of cases one is going to have stitch abscesses. The only other point that I might make is that we now have unequivocal evidence that if the patient during operation undergoes a period of shock and hypovolemia, this has a specific effect upon the healing wound. And when you find a patient who has, quote, an unexplained infection, particularly with staph, if you'll review the circumstances, you may find that this was a patient who during the operation had a rocky time, had a fall in blood pressure, had a transient period of shock, because at that time there's an acute drop in oxygen tension within the wound. And even though that may last only for an hour or so or less, it has a specific effect on making the wound vulnerable to bacteria that are implanted there at that time. So we feel that when you look at wound complications today, one must not only consider the technical factors of asepsis and so forth, but we've got to consider general systemic factors as well.
Dr. Dunphy, one brief point now with the matter of dealing with the skin. Do you recommend, if you do use it, the tape-type closure, and do you use a dressing, and do you feel that it plays any role in the management of the clean wound?
I think there's good laboratory evidence that a primarily closed wound is vulnerable to heavy surface contamination for about 4 or 5 days. And I think that in any wound which is likely to be exposed to contamination, some type of simple dressing to protect it for 4 or 5 days is reasonable. I realize that you can do it many times, just leave it out without any dressing at all and not get into infection. But I think from what laboratory studies are available, even the primarily closed wound is vulnerable to surface contamination for 4 or 5 days. The tape closure, I think, is ideal for small wounds, and particularly for wounds in which there's not deep subcutaneous tissue. If there is a lot of subcutaneous tissue, you must use some type of ancillary subcutaneous or almost subcuticular closure in addition to the use of tapes. Dr. Tom Hunt in our department has been studying the use of tapes now for several years, and the only area that he can show that there is really a significant difference between tape closure and suture closure as regards wound complications is in the contaminated wound. The wound that is minimally contaminated, not sufficient for you to feel that you ought to leave it open, which I think is the appropriate handling of a heavily contaminated wound. But it is in that wound, a colon resection, we'll say, that's gone quite satisfactorily. But there's some minimal contamination in these cases. We often have a hard time going back to remember when the wound becomes infected. But the incidence of sepsis in the subcutaneous tissue was less, significantly less, when tape closure was used than when suture closure was used.
What is the type of suture material that you use?
I think the peritoneum is reasonably closed with continuous catgut. I think any non-absorbable suture, or merceline, silk, is appropriate on the fascia and the skin, whatever your choice of sutures may be. For the vertical mattress suture that one buries, I rather think that the best suture, from the point of view of its reactivity in the wound and the strength which it provides, is still probably steel wire, but it has many other disadvantages. It's hard to handle. If you have it crimped at all in the peritoneal cavity, it may cause trouble. So that I tend, in the routine patient, I want to put a few buried retention sutures in, simply to use a piece of 0 or 1/0 catgut. In the patient that I'm worried about, likely to have sepsis or faulty healing, a lot of difficulty, I would probably use one of the plastic sutures, perhaps Teftec, something of that sort.
Okay. We'll continue with a presentation by Dr. Gans on hemorrhagic diathesis in surgical patients. Dr. Gans.
There are really three categories of affections that cause bleeding during surgery. One is the congenital defects, which can be picked up preoperatively by history and by testing. The majority of defects of the congenital variety are hemophilia and von Willebrand's disease. Hemophilia, as you know, can be picked up rather easily, both by history and by testing, especially with the PTT. Von Willebrand's disease may be very difficult to detect, since the only abnormality in the routine type of laboratory data is the prolongation of the bleeding time. The peculiarity of the von Willebrand's disease is that sometimes these patients have normal bleeding times, and that testing under experimental conditions, such as administration of aspirin, has to be instituted in order to pick up this condition. Markedly prolonged bleeding times are invariably found in these patients if you give them aspirin. The second category of abnormalities are the pre-existing acquired defects. There are three types: platelet-mediated ones, deficiency of vitamin K-dependent factors, and conditions that are associated with defibrillation. Now, the platelet-mediated defects can be picked up by doing a platelet count, by doing a bleeding time, by doing a clot retraction test. The majority of platelet-mediated defects are picked up in this fashion. Vitamin K-dependent factors are the factors 2, 7, 9, and 10. The majority of defects of these factors are picked up with the prothrombin time. Markedly prolonged prothrombin times are found particularly in patients who have factor 7 deficiency. Sometimes prothrombin time will be prolonged, and yet some of the vitamin K-dependent factors are not affected yet. This is in the early stages of anticoagulant therapy with vitamin K antagonists, since the half-life of the different clotting factors that are affected, 2, 7, 9, and 10, are different. 7 has the shortest half-life, and hence the prothrombin time becomes very early affected. The third defect is the defibrillation. Now, this is the defect we know least about. And at the vantage point that we are standing now, and 10 years hence, we may look at it completely different. But at the vantage point we are standing now, the best treatment, since the majority of the defects appear to be due to intravascular clotting, is to replenish the lost blood and the lost clotting factors, because those are the two main causes of bleeding in these patients. Primary fibrinolysis doesn't seem to occur too often. We really don't know the exact incidence. We would like to appeal to you to get as many studies on these patients so that we will gain more experience on this syndrome. Now, if blood, fresh blood or fresh frozen plasma or fresh platelet-rich plasma, since platelets are also depleted, and packed red cells, if this does not correct the condition, then one is obviously in trouble. And the question then occurs, what are we doing next? And this is where you are usually faced with in the operating room. If you do not have adequate facilities to test these patients, you are obviously flying by the seat of your pants. And then I would advise you to heparinize these patients, because very few of these patients develop primary fibrinolysis. The majority develop intravascular clotting. Now, when these patients come to autopsy, very few of these patients show actual fibrin emboli in the periphery. And this, of course, has been the big bugaboo in this particular area, because we had no criteria on which to base the diagnosis. The fibrin emboli, I can assure you, were present at one time. The effect of fibrin emboli takes a very short time to cause a great deal of havoc in the tissues. I just remind you that cerebral ischemia is only tolerated for a few minutes. Similarly, hepatic ischemia is tolerated for about 20-25 minutes, as we have learned now from liver transplantation work. And similarly, the various organs have a very narrow tolerance for ischemia. So if the fibrin is present, and if it eventually is broken down, and if you don't find it at autopsy, doesn't mean that the patient didn't have the disseminated intravascular clotting syndrome. This, I think, is one of the main lessons that we have learned the last few years. Now, what to do in those situations? As I have indicated, I would give heparin, unless I can demonstrate that we are not dealing with fibrinolysis. Now, what are the differential points? The points of the differential diagnosis between intravascular clotting and primary fibrinolysis. I'd like to point out again that in primary fibrinolysis, the platelet count is normal, the thrombin time is prolonged, and the peripheral blood smear is normal. Now, these are tests that can be done just outside the operating room by a laboratory technician and really don't take more than 15-20 minutes. In contrast, patients with disseminated intravascular clotting have low platelet counts, and platelet count now can be done very rapidly with the new electronic equipment. The thrombin time is normal, and the peripheral blood smear is greatly affected. I think that if we try to treat the patients on this basis, we might salvage a large number of patients that die now from the disseminated intravascular clotting syndrome.
The next speaker will be Dr. Claude Hitchcock. He will speak on aspiration pneumonia. Dr. Hitchcock.
Now, this problem, as we see it in our patients, cannot be distinguished, as far as the X-ray man is concerned, from any other kind of pneumonic process. Commonly, of course, when he knows the circumstances about the clinical situation, he can say, yes, this certainly looks like an aspiration pneumonia. Now, I took our hospital and surveyed our experience for a period of 5 years. And these are situations now that, according to our material of 31 patients, give us high-risk situations. The patient who is senile and debilitated, certainly the very physiologic factors of their debility and senility give us an increased chance of glottic insufficiency. Drug ingestion problems, the ethanosis patient, the alcohol, the minor tranquilizer problem, which is becoming so increasingly obvious and important in practice such as we see in, for example, our county hospital and the barbiturates. These would fall into the situation of drugs, of course, but so many of our patients who are hit by automobiles, suffer trauma, etc., need the emergency surgery, do have this kind of a basic problem that sets the stage for us. The next is the trauma situation. The patient who is unconscious, and there, of course, we have the problem of regurgitation of blood and, of course, gastric juice. The emergency surgery, then, a problem which brings us right up to the operating table itself. At this moment, perhaps would be best to mention that gastric juice, the hydrochloric acid of the gastric juice, is commonly the most serious material that we have to cope with as far as the effect on the tracheobronchial tree. This is quite definitely proved now with laboratory studies, and we know that as we go down in pH, we have an increasingly severe problem of irritation of the lung and an increasing problem of inflammatory response. We get to a pH of about 1.5, and it doesn't make any difference how much more concentrated you get beyond that. It's all pretty bad from there on down. Blood is not too bad, and commonly we can successfully treat a patient when they've had aspiration of only blood alone. The worst material of all, of course, would be fecal contaminated gastric juice from a patient with a longer standing bowel obstruction. This has been shown experimentally to be very serious, because even if you can get an animal or a human through the initial phases of the problem of aspiration pneumonia, they very commonly can then develop abscesses, multiple abscesses in the lung, and it's indeed a serious situation. The emergency surgery group we might look at for just a moment. My anesthesia colleagues in the city tell me, since we do not do very many tonsils and adenoids in our hospital and have very little experience with it, they tell me nonetheless that bleeding postoperatively from the TNA patient as much as the 3rd to the 6th day can be a very serious problem. I really wasn't aware of that, but they said in private hospitals in various communities, this is something that can cause a good deal of difficulty for the surgeon and anesthesiologists alike. The patient with a perforated duodenal ulcer or any other kind of perforation in the bowel requiring emergency surgery, of course, is prone for this. Upper gastrointestinal hemorrhage, the patient with varices and the duodenal ulcer that's bleeding. Here again, we have acid peptic juice that can be admixed with blood, and we have a very serious material as far as irritation is concerned. The regular bowel obstruction problem. Then trauma of all kinds, chest, abdominal, extremity, and head trauma too. Don't forget that when the patient is unconscious, has a serious head injury, this patient is not only a difficult problem in the operating table, but he can regurgitate and aspirate even right in his bed without too much trouble. Patients with caloric obstruction, then the usual other acute abdomens. Cesarean section patients. This, you remember, Mendelssohn was an obstetrician and gynecologist, and it was his specialty that really brought this to our attention, and we indeed have had several patients with this problem. Then vascular emergencies.
Excuse me, Dr. Hitchcock, momentarily, to say that this, doctor, is the end of Side A of your program. Dr. Hitchcock continues his discussion of aspiration pneumonia on Side B, heard by simply flipping over the cassette or 2 reels on your tape recorder. Continuing a program on intraoperative problems, this is Audio Digest Surgery, Volume 17, Number 8. Resuming his discussion on aspiration pneumonia, here once again, Dr. Claude R. Hitchcock.
Now, as far as precautions are concerned, a few things that we think have helped us in our hospital. In the trauma patient, where we so commonly have to cope with this problem, one of the most important things is prevention. And all I can say that would really set the stage for you here is to let the red flag of caution wave whenever a patient requiring emergency surgery is going to the operating room, and be sure that everybody involved with you in the case, including the residents, interns, the anesthesiology people, assume that the patient has recently had food and be prepared for his subsequent regurgitation and possible aspiration. We find that the use of a large Ewald or Boas tube is not too effective. We all say that this is the way to handle these problems. Put the big tube down, wash out, gavage out the stomach. But as we've tried this over the years, our patient is needing surgery in a matter of the next relative few minutes and so on. It simply doesn't work well. We cannot clean it out sufficiently and adequately, so we pass a 9 9-hole nasogastric tube. But I would point this out to you, that it's common practice all over this country to tie knots or otherwise obstruct that tube while the patient is being moved around the hospital. Again, you have compounded your problem by having a good wick down the esophagus, completely inactivating any possible mechanism from the cardioesophageal mechanism as a sphincter-type mechanism, or possibly the cricopharyngeus muscle, and now you have some gas and fluid in the stomach. The wick is there. It's not able to drain anything off, and of course you simply have compounded your problem. We like to just take a glove and tie it on the end of the tube and send the patient around up to the operating room that way. Now, we like regional or spinal anesthesia in these traumatized patients, if at all possible, and this is what we use. In the aged and the senile, remember that you can compound your problem again with too much sedation and tranquilizers. In fact, I forbade the use of tranquilizers on any of our older patients in my hospital because some years ago, as they became popular, this did become an increasing problem. Chest and abdominal surgical cases. Our men often at the head of the table intubate our patients so-called awake. They use a cyclane spray in the hypopharynx and just with a minimal amount of spray get their tube in quickly and then have things under control by blowing up the intratracheal bag, and they can then suck out the patient and keep him under safe conditions. There is a new type of balloon. There are several on the market. One is the Moss balloon, which has or tube rather, which has a small gastric balloon. And it can be used, and I think perhaps in common usage in a given hospital might well help to minimize the problem of aspiration. And then little cricoid compression technique, which actually was sort of new to me. Our anesthesiologist brought this to my attention. It's being published now, particularly in the British literature. And this is a simple method of pressing on the cricoid and compressing the esophagus against the vertebral bodies. And the British have pointed out that one can quite effectively, without doing anything to the competence of the airway, one can quite effectively compress the esophagus at this point during an immediate critical situation and prevent regurgitation. Now, just a little bit about our own patients. The bulk of the problems occur during induction and during the maintenance of the anesthetic itself. The treatment that was used in the various cases, suction, of course, is absolutely sensible and important. Saline, intratracheal irrigation with saline. Now, I believe that there is no evidence whatsoever to support the use of large volumes of saline in a gavage technique. In fact, I think it's harmful. I think we tend to wash out various materials that are of great importance to the tracheobronchial tree, and so we use only small amounts of 5 to 10 cc's to irrigate and wash out. Antibiotics are commonly used in our hospital. Steroids in serious cases are used, and bronchoscopy only in those patients where we feel that there has been a problem of solid or particulate matter. Now, I would point out to you that of 13 patients, the mortality was only 23%, which is not too bad. I think it represents the fact that good anesthesia is being practiced, and we have good teamwork between the surgeon and anesthesiology service. Now, here then is the basis of treatment that I think can help us all. If solid materials are involved, bronchoscope your patient immediately and clean him out so that you don't have persistent atelectasis. If it's a liquid situation, which is much more common, suction the patient. Wash the trachea with saline, small amounts, and do it several times. Antibiotics of a broad spectrum type, I think, are mandatory and should be started, preferably intravenously, immediately when the insult has occurred. I think steroids are useful. I do not think that they should be used in the tracheobronchial tree itself as part of the washout mechanism. I think there is no evidence whatsoever that this has been helpful. On the other hand, we think that using steroids intravenously in large doses for the anti-inflammatory effect can help in the management of these patients. Then IPPB using saline and mucomist, and about at this point comes tracheostomy. And we do a tracheostomy in our patients only when the situation is such that we feel it is getting out of control, the patient's general clinical course is degenerating, and then we, of course, do the tracheostomy and put him on positive pressure. Now, I would say that at this point we have found that volume-regulated respirators are superior to the pressure-regulated. There's a new one on the market in the country, the Emerson MV50, I think is the name of it, and we have found it to be a very useful unit, and it really helps our patients a lot. Then we find that it's now important to monitor the PO2 and the PCO2 of these patients directly. These are blood gas determinations. And we have found oftentimes that while the patient didn't look too bad, when we would do the PO2 and the PCO2, we'd find that he'd be carrying a PO2 of about 40. And in that circumstance, we then get a tracheostomy done, get the patient on good positive pressure maintenance, and I think have brought some of them through.
We'll proceed now with the next speaker on appropriate monitoring in the poor risk surgical patient by Louis Del Gurcio. Dr. Del Gurcio.
Monitoring for arrhythmias electrocardiographically we're all aware of, but really gives us very little specific information regarding blood flow. For instance, if you have a patient with a myocardial infarction following major surgery, his electrocardiograph and his rhythm may be perfectly beautiful for long periods of time, at a time when actual blood flow, total blood flow as represented by the cardiac index, is falling precipitously. And if under those circumstances you were aware of this, you might be able to do something about it, particularly in these days when we're beginning to think of support of the circulation and other techniques. Now, the simplest way of estimating total blood flow and its adequacy for the support of the whole body as far as the delivery of oxygen, the little two-syringe technique. John Border originally thought of this wonderful little gadget, and that's described in the Journal of Trauma, Volume 6, 1966. What it really consists of is the 10 cc syringe contains the unsaturated blood. Now, if you have a bubble of pure oxygen, which you draw up from an oxygen line, it doesn't matter really how large that bubble is, except that you don't want it too large, because if it's so large, then it'll allow carbon dioxide to go into the bubble, and you won't actually measure a decrease in the size of the bubble on the basis of the manometer. But it stands to reason that as that bubble of oxygen is used up, the volume of the whole system will go down. And as long as you don't move the plunger of the big syringe, as long as you keep that fixed, then you will be able to measure how much of that bubble has been used up by the 10 cc's of blood. And if 10 cc's of blood use up half a cc of oxygen, multiplying by 10 to give you volumes per 100 cc's or volumes percent, then gives you the volumes percent of oxygen which it takes to fully saturate the mixed venous blood. And if you assume that the arterial oxygen is 100% saturated or close to it, then what you have is your actual AV difference. But it doesn't really matter whether or not the arterial blood is 100% saturated, because if you find that your mixed venous blood is black and very much unsaturated, you can be certain that the cardiac output is going to be low, or that the arterial oxygen saturation is going to be low. In either case, this serves as a very effective warning to you that something drastically wrong has happened. The advantage of that is that the total cost is zero. No one works in a hospital that doesn't have 10 cc syringes, that doesn't have oxygen, and that doesn't have tuberculin syringes. So that it's a very simple thing to do, and we have maybe $500,000 worth of equipment in our laboratories and in our special center, and I'd hate to tell you how often I'm forced to use that little cheap gadget to get the answers that I want in the middle of the night. So that it's something for us all to remember, regardless of our resources. Now, to go one step further, if the hospital is willing to invest in something more from the standpoint of patient monitoring for use with the severe trauma case, the automobile accident that comes in the middle of the night where you think that you've caught up on blood loss and yet the central venous pressure is rising, and you want to know whether or not this is a real problem of overtransfusion or whether there may be some element of heart failure involved because of either trauma or possibly because you suspect a hemopericardium or something of that sort. The only thing which will give you the answer is to somehow measure the cardiac output. Now, you can buy a shock cart which will give you a recording of the indicator dilution curve, the pressure pulses, a recording of the central venous pressure. It will give you an EKG superimposed upon this. You can have a built-in analog computer to automatically measure the cardiac output. You can get all of this for about $10,000 totally. This means that as soon as something goes wrong in the operating room and the patient is hypotensive, this device can be wheeled in. Whoever runs it will then be able to tell you exactly what the entire cardiovascular status is, to know whether to stop the case or whether to digitalize the patient or whether it's primarily a problem of hypoxemia and so forth. Now, this implies that that initial expense of $10,000 is nothing compared to the expense of educating someone in the electronics and in the physiology required if that's all that they're going to do in the hospital setting. And if you have a hospital of more than 300 beds, I would be willing to bet on statistical grounds that there is someone in that hospital at all times who would benefit from the use of that type of equipment in studying what his basic problem is. There is almost always somebody in some form of shock or another, or who is so desperately ill that this type of physiologic information would be of value to him. So that the expense is not just the original equipment, but it's the expense of time, and the time that we have to take out to learn how to use these things. Because if the physicians and the surgeons don't do it, you're never going to be able to have a technician who will have the interest in doing it, and you won't be able to check on his satisfactory results unless you know yourself. Now, $10,000 is a lot of money, but a Gilson densitometer, which is the least expensive, and by the way, one of the best of the densitometers, costs around $700. That's the major item of expense, and it's the one essential item. You need some form of a recorder to record the indicator dilution curve, and an ordinary EKG recorder has usually a plug-in jack which will enable you to put the signal from the densitometer into that particular recorder, and it gives a perfectly useful dye curve. As far as calculating the cardiac output from the dye curve, this is simply a matter of measuring the area under that curve, which can be done with an integrator of some sort or with a computer, and then excluding the recirculation, which represents dye which has come back a second time into the circulation and which you want to exclude. This can be done with the nomogram or special types of computers. A nomogram, by which use you can figure the cardiac output in less than 5 or 10 seconds, does all of the calculations automatically that are done in the computer. So that a simple nomogram is much lighter than a computer, of course, and costs you nothing. I'll be happy to send one to any of you who would like to have one. So that the total expense there for the whole system for measuring cardiac output in your hospital would be somewhere between $1,000 and $1,500. And as far as the value of this in patients, there comes a stage when you don't know whether the patient is doing badly because they have too low a cardiac output or because it's primarily a pulmonary problem. We know now that there are certain shock states which are primarily a high cardiac output form of shock, which carry a very poor prognosis. We've found it impossible to take care of patients adequately without measuring the cardiac output itself. In closing, I'd just like to say that there are some 9 million elective operations performed in this country every year, and that of this vast number, there are a certain percentage who die as a result of the surgery. I think that it is incredible in this day and age that we cannot predict on every individual patient undergoing elective surgery whether or not he will have the wherewithal to survive the post-operative period. I think that when we can put a man on the moon, if we can't establish enough equipment in hospitals to evaluate properly whether his cardiorespiratory system can carry him through, then there's something wrong with American medicine. And I think that the instrument manufacturers are willing to come across with the type of equipment which can be used with simplicity and safety in every hospital if the physicians and surgeons indicate to them exactly what they want. And I think that we're going through a growth phase now where we're going to see the instrument manufacturers more and more interested in giving us what we want. We simply have to tell them what we want and how we are going to use it.
We will now hear from Dr. George Clues, who will speak on the treatment of acute peritonitis. Dr. Clues.
Peritonitis is a problem that's with every surgeon all of the time. One cannot open the abdomen without establishing some inflammatory reaction in the serosa or parietal peritoneum, and this is the protective mechanism which prevents our intestinal anastomoses from leaking and takes care of the multiple other situations that occur where minor infection or inflammatory material from the GI tract or other sources may be present. In other words, it's protective, but at the same time, it may be lethal if we get massive infection. I would like to consider with you what I consider to be the two main principles involved in getting people well from peritonitis. The first is the isolation of the infectious agent and its final resolution and recovery. And the second aspect of the problem is the metabolic support which is required to enable the patient to make the same set of reactions that he would under any circumstance, but to reinforce it. Now, invasive sepsis, which might be like peritonitis with a perforated cecum, a gangrenous cecum, leads to bacteremia, tissue necrosis, and circulating toxic agents, all of which go on through this series of unfortunate circumstances to shock and death. On the other hand, if the patient's responses are adequate in terms of his cardiovascular, respiratory, immunological responses, active RE system, all under control of the neuroendocrine system, then he may get on to a state in which the infection is localized. And we're all familiar with that in peritonitis, in which we see if we can stop the source of contamination, that we wall off localized abscesses in the gutters, in the pelvis, subdiaphragmatic. Then there's a set of circumstances here which are required for recovery. The cardiac output is usually up somewhere from 50 to 150% above the resting level, whereas the metabolic rate may be only up 15 to 40 or 50%. Respiratory effort is required, and we have the inflammatory situation with its multiple AV shunts. Finally, the situation resolves when the abscess is drained and when healing takes place or when it's reabsorbed. Now, at this point, what can we do? We can use chemotherapy to help the patient localize this infection. The next matter of controlling invasive sepsis, obviously, is the resection or exteriorization of a source of contamination or its prevention. And I think a fine example of that is the reduction in mortality that's been affected from approximately 50% to around 25% by resecting the perforated diverticulitis over the better results obtained from that instead of simply a transverse colostomy. Now then, what do we do when the patient has succeeded in localizing the infection? Well, obviously, you have to drain the abscesses to expedite the removal of this, or else this situation will continue. I would like to point out the physiological problems involved where we can do real good by support of the patient while he's going through this stage of localization and resolution of his infection. The minor type of peritonitis that we get in the postoperative patient who has a sore belly for a few days and maybe a little ileus is not a stress that we have to worry about. As I see it, the chief problems that confront the surgeon who is taking care of the seriously sick patient with peritonitis are circulatory, respiratory, and energy expenditure problems or caloric problems. Failure of caloric expenditure or caloric supplies, the great cause of death in these people. There is a situation, to begin with, in people who are septic, post-traumatic, post-shock, in which they resemble diabetics. If you do a glucose tolerance curve, as we've been doing lately on our service, you find that they are diabetic type tolerance curves, and then they revert later on to normal ones as the patient gets well. And the interesting thing is that the insulin production in these people is reduced. The result is that they mobilize carbohydrate to a greater degree than the normal individual from any source available. Well, after the first few hours of starvation, under stress, the only source is protein. The result is then that a great deal of gluconeogenesis goes on by proteolysis, and this is where this problem of weakness leads to respiratory failure and final death, usually in the later stages. I think a great contribution has been made by Dr. Dudrick in terms of his intravenous alimentation and caring for just this situation, and I can stand here and say that it works. The other thing is Dr. Randall of Providence has made a contribution in what he refers to as his elemental diet. Well, any one of you can make an elemental diet out of amino acids and carbohydrate and perhaps a little fat and use it through a gastric tube. The real problem with these people are the intestinal fistulae that they develop due to rupture of abscesses into the intestine, and sometimes it's very difficult to feed them. But this is the last great problem that presents the surgeon who's dealing with such a patient. Now, in short, what we're trying to do is to convert the set of responses caused by the presence of toxicity, toxic agents from the injured septic tissue, from a vicious circle leading to further tissue destruction and death into a normal set of responses that lead to survival and recovery.
Dr. Clues, do you want to comment on the matter of irrigations for generalized peritonitis?
One can use kanamycin and neomycin in a mixture of approximately, 500 cc's of saline, and the point that you want to remember is that there's a real danger of apnea with these drugs following irrigation. Now, in relation to their effectiveness, I think the work that John Davis and others have done, particularly Isidore Cohn and his associates, on the merits of irrigating the peritoneum with kanamycin or neomycin has led me to believe that this is a worthwhile thing to do while you're there. That doesn't mean that it's going to take the place of proper therapy in every other respect. Now, as far as peritoneal installation through a catheter placed at the time of operation, I have grave doubts as to whether this really accomplishes anything or not. Everything we know about the effectiveness of treatment of peritonitis depends on walling off of an area or isolation of infection into multiple little abscesses. And if this is true, then how can you irrigate such an area with a catheter placed? All you're doing is irrigating the one tract that it's in. I don't know the answer to that. Vicente and Cohn have published on this, and those of you who are interested can look it up. It's in the American Journal of Surgery in 1966.
I'd like to ask you to dwell very briefly on your concept of the role of steroids in sepsis with hypotension, the other things.
I see the potent corticosteroids that we now have available therapeutically used in two ways. One has been mentioned in connection with its anti-inflammatory activity. It can be quite dramatic how a patient who's in terrible trouble with a ventilation perfusion ratio and hypoxemia difficulty, areas of lung unventilated due to inflammation, how within 4 hours after starting massive doses of steroids on the respirator, you will see the compliance of the lung improve. In other words, it takes less pressure to force in a given volume of air through the endotracheal tube or the tracheostomy tube. Secondly, you'll see the oxygen tension in the arterial blood rise relative to the oxygen tension that's going in with a respiratory mixture, so that the AA gradient becomes less. I think this same thing holds good in the periphery, and that's why we see the circulatory improvement that goes on with glucocorticoids. The membranes, by some mechanism or other, which I don't believe is understood, have their permeability decreased in the inflammatory state by the presence of large quantities of these corticoids. The result is that there's less fluid filtered and the edema subsides. You've all seen this happen. It works just as well with peritonitis. And I think herein is where the real merit of this stuff is concerned with circulatory difficulties. However, the point that remains is that if it doesn't work within a few hours, it isn't going to work. And if your patient doesn't improve within a day or two of the institution of corticoids, even though they have worked, you cannot keep it up. It just won't go on and on and on. It's not a panacea. So that this is a stopgap measure that will get you over the shock state of circulatory failure or respiratory failure, but there's no magic in it.
Thank you, gentlemen. Testifying to the hazards of IV polyethylene catheters, Nashville's Bruce Belazny and colleagues report that in 105 consecutive surgical patients, after 24 hours or more, 13% had positive bacterial cultures from the catheter tops. 12% developed thrombophlebitis. Even more serious, 2 patients developed frank septicemia. Although percutaneous venipuncture was less hazardous than venous cut-down, both methods had dramatic increases in complications as the days passed. The authors blame most of the problems on inadequate aseptic techniques and advise that if venipuncture is to be used, you shave the skin, scrub it with surgical soap, and paint it with an antibacterial solution. Sterile gloves should be worn so the vein can be stabilized without contaminating the prepared skin. The puncture site is essentially a fresh surgical wound and should be dressed as such. In doing a cut-down, the authors suggest wearing cap, mask, and gown. Special attention should be given to draping the sterile field if you're using long catheters, because they stray easily from a narrowly draped field. The 12% incidence of patients developing thrombophlebitis without positive bacterial cultures suggests polyethylene catheters can be irritating to vein walls without bacterial superimposition. Substituting silicone rubber catheters may be helpful. As to how long catheters can be left in with safety, the authors recommend removal within 12 to 24 hours if strict antibacterial precautions haven't been followed during insertion. And with that item, we conclude this edition of Audio Digest Surgery, produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. Thank you, Doctor, for listening.